طيب السلام عليكم. Our lecture today is a bit shorter than yesterday, so we have more room for discussion. So we're going to talk about hypofunction and a few other topics, including polyglandular autoimmune syndrome. Right, so we're going to start first with adrenal insufficiency, and we mentioned before that adrenal insufficiency could be primary or secondary. Primary when there is autoimmune destruction of both adrenal glands, so we lose the function of the cortex entirely, okay? Meaning we have glucocorticoid deficiency and mineralocorticoid deficiency. بينما secondary adrenal insufficiency, because of a higher center, whether it's the pituitary or hypothalamus, we lose the function of ACTH only, and ACTH affects the cortisol production. So the mineralocorticoid axis is intact. Okay, so that's an important distinction. I mentioned here post-bilateral adrenal infarction or adrenalectomy. I might have misplaced this, but هي ضايعة بين the primary and secondary. What do you think after bilateral infarction, what will happen to the ACTH? It will increase, صح? تمام. So I don't know where to put it, whether it's primary or secondary. لكن I put it here, but anyway, remember that post-bilateral infarction or adrenalectomy, you have high ACTH, and you have also a complete loss of the adrenal gland secretions. So you need to replace both mineralocorticoid and glucocorticoid. This is one of the early descriptions of Addison's disease, reported in 1855. What can we see in this young man? Hyperpigmentation and maybe gynecomastia, maybe I'll take that. Yes, hypogonadism ممكن يكون عندهم. These areas or patches, what could they be? Vitiligo. So vitiligo is another autoimmune disorder. Yeah. Vitiligo is another autoimmune disorder that can happen in combination with other autoimmune disorders related to the endocrine system. So let's mention some of those. What do you guys know of other autoimmune disorders that can happen with Addison's? Thyroid meaning what? Yeah. Hashimoto, Graves, type 1 diabetes, primary ovarian failure. That's one thing can happen for man. Hypoparathyroidism, صحيح, autoimmune hypoparathyroidism. So these are clusters of disorders that can happen in the same patient, not necessarily at the same time, but the patient can have a constellation of these symptoms or disorders. حتى sequentially over time, they can acquire more and more. We're going to talk about something called polyglandular autoimmune syndrome at the end of the lecture. Okay, I just brought it here and we already have maybe 2 or 3 manifestations in the same patient. Okay. طيب, how does adrenal insufficiency present? Usually, for example, an undiagnosed patient with adrenal insufficiency following acute stress. Remember, type 1 diabetes. Does it happen all of a sudden? Well, it takes time to progress and develop. It takes time. And then something happens to the patient, an infection, a sore throat, diarrhea, stress, بيدخل بإيش? DKA. So the first presentation is a DKA because of something secondary that happened. لكن type 1 diabetes don't necessarily go into DKA if they were fine otherwise, okay? The same thing goes here. Somebody with adrenal insufficiency, Addison's disease, they might start having fatigue, شوية hyperpigmentation, شوية nausea, and then suddenly they get an infection. They go into adrenal crisis, hypotension, severe illness, hypoglycemia, and other things, okay? So it's a slow onset of symptoms, but something pushes you into acute decompensation. Also, another example is adrenal insufficiency who did not take more glucocorticoid during acute illness. We talked about the sick day rules. If you are adrenal insufficient and you get a fever, you need to double your dose of hydrocortisone. If you get into a road traffic accident, stress of maybe حتى exam, يعني ممكن يكون, you have to double the dose of your steroids. If you don't do that, you might risk going into adrenal crisis. After bilateral adrenal infarction, or bilateral adrenal hemorrhage. كمان this is an acute event. ممكن يكون عندي مريض presenting with pulmonary embolism. طيب, how do we treat pulmonary embolism? Anticoagulation. We give them anticoagulation, and that might lead to bleeding elsewhere. ممكن some people will have spontaneous bilateral adrenal hemorrhage, bleeding into the adrenals because of what? Anticoagulation. So that adrenal hemorrhage will make you lose the function of the adrenal gland acutely. So these people can present with acute adrenal crisis. طبعا acute cortisol deficiency due to pituitary infarction. We talked about this as well. What is an example of this condition? شيهان, ممتاز. أو apoplexy, pituitary apoplexy, تمام? That can also cause this condition. Symptoms and signs of adrenal insufficiency: dehydration, hypotension, shock, out of proportion to severity of current illness, nausea, vomiting, abdominal pain, which is يعني not localizing, unexplained hypoglycemia, unexplained fever, hyponatremia, hyperkalemia, eosinophilia. This is one of the interesting features of adrenal insufficiency. Hyperpigmentation or vitiligo, other autoimmune endocrine disorders. Okay. طيب, I'll give you another example. In my clinic yesterday, إحنا اليوم إيش? Monday. In my clinic yesterday, I had a patient who is 37 years old. First visit to me. طيب. The reason she's coming to me is hypocalcemia. Hypocalcemia. I measured her PTH, and it's also very, very low. So this is what? Primary hypoparathyroidism. This is an autoimmune disorder. Tamam? This is an autoimmune disorder. She had it for 12 years. But when I first saw this patient in my clinic yesterday, first time, I ordered some additional tests. Who can imagine what those tests could be? Kidney function was normal. But I'm saying in the same field that we're just discussing now.
Magnesium?
Magnesium is fine. Calcium is low. Cortisol. ليش cortisol? تمام. This is an autoimmune disorder, صح? I want to check other common autoimmune disorders. So I measured her cortisol and ACTH and they were normal. What else did I check?
Thyroid.
Thyroid. I measured her TSH and free T4. They were normal. What else did I check? صح. عملت لها hemoglobin A1C. I want to know if she has diabetes or not. It was normal. I looked at her skin. What am I interested in her skin? Vitiligo. Tamam? So remember, autoimmune disorders can present by themselves, or they can present with other things. So you don't want to miss those other things. Okay? ممتاز. Here is an example of a patient with hyperpigmentation because of primary adrenal insufficiency. You can see the hands are hyperpigmented compared to a normal hand. And after treatment with steroids, the hyperpigmentation resolves. Okay? So how do we investigate somebody with primary adrenal insufficiency? We measure their ACTH level, we measure their cortisol level. Typically, the ACTH is what? High. Cortisol is low. Sometimes, يعني the picture is not very clear. ممكن يكون inappropriately normal ACTH مثلا أو شيء من هالكلام. So what is an additional test that I can use? ACTH stimulation test. Who can tell me how we do this test in the clinic? صحيح.
She has disease, there will be no response.
ممتاز. So we stimulate the patient with ACTH. We have it as a medication. And we measure the cortisol at baseline to know what's the cortisol at baseline. وبعدين at 30 minutes and at 60 minutes. And we see the peak. Where does it peak? If it goes beyond 500, this is a normal response. If it goes up but not to that level, or no response حتى, we know that the patient has adrenal insufficiency. Yes.
Whites actually in cases after giving the cortisol whites in cases after giving ACTH, why the problem is seen and adrenal insufficiency.
لا نحن we're testing to see if the adrenal is affected or not. بالناس اللي عندهم primary adrenal insufficiency, the response is near zero. لأنه الadrenal gland is already atrophied with small. Whatever you give ACTH, you will not get a response. I'm saying that sometimes we are not certain of the diagnosis. We want to rule out. حتشوفوها كتير بالمedicine. يعني when you work in medicine, بيجيك مريض بالER, sick, nausea, vomiting, hypotensive. We do it on the spot. عرفت علي؟ We don't know, is it acute adrenal insufficiency or is it sepsis? You know, that's the thing. تمام. ممتاز. So if somebody comes to me with features of adrenal insufficiency, high ACTH, low cortisol, do I need to do pituitary imaging? No, لأنه I know that the pituitary is healthy. Why is it healthy? عم تفرز a lot of ACTH. Okay, so the problem is not in the pituitary. Problem is in the primary adrenals نفسهم. ممتاز. Sometimes we go into adrenal imaging. حكينا بعض السيناريوز اللي هي bleeding ولا metastasis ولا something into the adrenals. So we need to look into that and make a diagnosis. How do we treat patients with primary adrenal insufficiency? We have to replace both glucocorticoids and mineralocorticoids. This is contrary to secondary adrenal insufficiency, where mineralocorticoids do not need to be replaced. Sick day management is very important. Anybody coming to me with Addison's disease, I teach them every visit. حتى I mentioned this. If you get sick, if you have a fever, if you get into an accident, please double your dose of hydrocortisone. بيسألني المريض, how many days يا دكتور? 3, 4, 5, 6 days until you feel better. Then you go back to your regular dose. Okay? Yes.
So in the previous slide, first slide, you said like in patient who had adrenalectomy, we will replace adrenal
Yes.
and
Absolutely. Absolutely.
and here is only the primary one.
شوف الادرينالكتومي حايرة شوي. I don't know where to place it, primary or secondary. بس when you remove both adrenals, it's just exactly as if you destroyed both adrenals. سواء كان autoimmune destruction ولا metastatic destruction ولا bleeding destruction. So anything that destroys your adrenal, you need to replace both mineralocorticoid and glucocorticoid. تمام؟ أو حتى if you remove them. يعني نفس الفكرة. طيب. These are medical. Yes, تفضل.
Is it possible they can sometimes overtake those steroids
طبعا.
when double the dose?
لا ما حيكون عندك short term affection, no. But sometimes what can happen when we replace steroids for some patients, we can overdo it. ومندخلهم بإيش؟ Cushing. So we have to be very careful with steroids. One of the problem of steroids is that I do not have a test to tell me if the dose is adequate or not. So I depend on symptomatology. يعني بيجيني مريض adrenal insufficiency. مثلا أعطيك مثال. Adrenal insufficiency today, the first visit. أول مرة بنكتشف الموضوع. We give 10 milligram of hydrocortisone in the morning, 5 milligram in the afternoon أو مغرب, وقت المغرب عموما. The patient comes to me after a month. والله يا دكتور, I'm still fatigued. I'm unable to go to work. I'm losing weight still. طيب ممتاز. Let's increase the dose a little bit. So بعطيهم 15 هيدروكورتيزون الصباح و5 المغرب. بيرجع لي بعد شهرين. I'm still not myself, you know. So you keep going and increasing the steroids. لأنه ما عندي test, biochemical test to tell me that this replacement is physiologically adequate or not. Compare this or contrast this with hypothyroidism. يجيني مريض hypothyroid. TSH is high, free T4 is low. I give levothyroxine, weight-based initially, وبعدين I adjust. If the patient comes to me after 6 weeks and I measure the TSH normal, levothyroxine, free T4 normal, خلاص, I know that this is the adequate dose based on biochemical testing, not based on symptoms. So adrenal insufficiency is symptom-based when you adjust the dose. فممكن بعض المرضى they push you into increasing the dose, which might be a bit too much for them. Okay, yes.
Do we have to taper after 5 days when they double the dose?
Yes, no tapering, just go back to normal. Excellent point. موضوع مهم جدا. We get a lot of calls from our colleagues in the hospital about this. مريض عنده Crohn's disease. Acute flare. طيب. They give the patient 60 milligrams of prednisone daily for 3 weeks. تمام. وبعدين they give us a call. The patient now is better. We want to start tapering the dose. Can we stop it completely ولا we should taper? لا, the answer is you should taper. So anything beyond 2 weeks عادة, high dose of steroids beyond 2 weeks, you need to taper down the dose. Why do we need to taper down the dose? لأنه this huge dose, what did it do to my ACTH? It shut it down, صح? So if I stop steroids immediately, حيصير عندي crisis. My ACTH is not back to normal. So we gradually decrease the dose and taper it down. This is a very common scenario in the hospital. We get asked a lot about this.
Anything less than 2 weeks, you don't.
Typically high doses less than 2 weeks, I feel comfortable and ممكن we can stop it. عرفت علي? Anything beyond that, that you should taper it down. This is the general rule. Okay. Right. ممتاز. So طيب, the next topic we're going to talk about is adrenal incidentalomas. Okay. An adrenal mass, which is more than 1 centimeter, discovered serendipitously or incidentally by radiological examination. طيب. Now, I get a lot of these cases as well as an endocrinologist. When I get this patient into my clinic, I have 2 questions I need to answer. Is this mass benign or cancer? Number 2, is it functioning or non-functioning? You are in my clinic now, and I have a patient with a 3 centimeter right adrenal mass. What should I do?
This age.
Age is 30. ممتاز. يا جماعة ما تنسوا انتوا يعني you're geared towards investigation, بس ما تنسوا انه في شيء اسمه history, في شيء اسمه exam, صح؟ Don't يعني overcome these or don't skip those. What are the questions that you're interested in asking this patient with a 3 centimeter adrenal mass? حلو. Do you have hypertension? Do you have headaches? ليش headaches? حلو. Hypertension أو pheochromocytoma. What else? ممتاز. What else? What is it? ممتاز. So you have in your mind 3 conditions that you want to ask questions about. What are those 3 conditions? Pheochromocytoma, Cushing, hyperaldo, صح? I know it's an adrenal mass. إذا في عندي excessive production حيكون one of those 3. Rarely in females حيكون عندي an additional type of hormone I need to look for. Gonadal, hyperandrogenemia, صح? So these are the questions. تجيني مريضة with a 3 centimeter adrenal mass. What can I ask her about hyperandrogenemia? Questions. Hirsutism. Are you noticing excessive facial hair? Do you have to shave your facial hair? Have you noticed excessive body hair, for example? Another question, how is your period? Is it regular? Is it not regular? You know, that sort of thing. Right. So to determine if it's hormonally active or not, we start with history and physical exam. Physical exam, what can we look for? Stretch marks, moon face, hirsutism, other features of Cushing that we talked about. الهايبرالدو ما فيها clinical findings عموما. ممكن شوية swelling in the feet, ممكن شوية edema. الفيو طبعا hypertension, you're absolutely right, it's part of physical exam. الفيو is basically best blood pressure كمان, usually, nothing much on physical exam. خلصنا history of physical, now we go into testing. What do you want to test in these patients? Screening حلو. Screening for what? For Cushing, صح? You're thinking of Cushing now. So you're going to do some screening tests. ممتاز. We know those screening tests. 24-hour urine cortisol, 1 milligram dex suppression, late night salivary cortisol. These are screening. حلو كتير. What else? If the patient is hypertensive, what can I do also? Metanephrines. What's more important?
Not the name, is the broken down.
I want you just to remember metanephrines. Let's keep life simple. You're absolutely right. I know where you're going. But see, فعليا, the test that we order in the system is 24-hour urine metanephrines. عندي norepinephrine, عندي الابي norepinephrines, basically عندك الابinephrine والnorepinephrine أو اللي هي what is it called?
The molecule after breaking down epinephrine and not.
You're right. I agree with you.
VMA and.
In general, يعني, I would not test you on these minor things. I just want you to know that this is we look 24-hour urine catecholamines أو الميتانephrines, الميتابولايتس تبع الcatecholamines. طيب, what about aldosterone? Are you interested in measuring aldosterone? Yes.
Potassium and
Potassium is very important. You're absolutely right. وبعدين we measure aldosterone and renin, and if aldosterone is high, renin is, the things that we talked about. حلو. So this basically is the way to answer the second question. Is it hormonally active? So history, physical, or biochemical testing. But what about cancer risk? how can we assess the cancerous? ممتاز. We do imaging. Usually it's CT. Nuclear medicine does not have a role here. عموما. ممتاز. Biopsy. Biopsy has almost zero role, almost. بس في one scenario, I'm going to tell you about it when we would do a biopsy. بس يعني biopsy is not something that I would go for in general. هنحكي بهذا الexception. Yes. So خلينا نشوف what we can do. طبعا adrenal incidentalomas, depending on the population you're studying, vary from 0.4 to 10% of CT scans. Can you imagine 10% of your CT scans coming back with an adrenal mass, which was not expected before? High volume. Well, this number is probably طبعا excessive. In our hospital, I would estimate maybe 5%. So we do get a lot of these cases. من وين? Who can give me a scenario where an incidental adrenal mass is detected?
Breast cancer, for example.
Breast cancer, doing what? What kind of study? Maybe PET scan. الانكولوجيست طلب PET scan لحتى يشوف لو في عنده أي يعني metastasis. Then we pick up a small adrenal mass.
Doing a CT, suspecting a stone, adrenal stone.
ممتاز. Excellent. ممتاز.
Pulmonary, maybe,
Pulmonary إيش?
like from metastasis, from like lung cancer.
From colon cancer, lung cancer. حلو. So chest CT usually stops at the diaphragm عادة. However, I can tell you that sometimes they can pick up the upper part of an adrenal mass and they tell you, please order an abdominal CT. I take that. ممتاز. So these are the things that can happen in clinical practice. طيب, bilateral masses are less common. So usually you're dealing with a unilateral mass. Bilateral masses would make me think of other things like congenital adrenal hyperplasia, adrenal metastasis from somewhere else. Tuberculosis, widespread tuberculosis can affect both adrenals. Hemorrhage because of anticoagulation, for example, we can have bleeding into both adrenals. Right. One important message that I deliver to my patients in general, if it's a small and يعني not scary looking adrenal mass, that the most common masses, or commonly those masses are benign. Okay, commonly they are benign. Here are some examples. This is an 8 centimeter left adrenal mass, which is clinically silent pheochromocytoma. Can you imagine that? Clinically silent, يعني المريض ما عنده features of pheochromocytoma ولا symptoms. However, the mass is huge. بالفيميل سايد وحده سالت انه طب how come you told us يا دكتور انه الميتانفرنز لازم يكونوا 3 or 4 times the upper limit of normal to call it pheo. Sometimes pheochromocytoma can come with 10x upper limit of normal. Okay, not just 3 and 4. So they have a lot of metanephrine secretion. So that these masses, when they're huge and the patient is asymptomatic, it makes me think of the inefficiency of this tumor in producing metanephrine. So they qualify for pheochromocytoma لأنه the level is 3 times the upper limit of normal. But for the size, in normal cases, I would expect it to be times 10. But here it's only times 3. That's why they're not يعني there is no symptoms. طبعا شوفوا, this is an exception, not the rule, okay? This is an exception. But it's interesting. We do see these variations in clinical practice. طيب, a 1.5 centimeter adrenal adenoma, Hounsfield unit 4. We're going to talk about this, what is the meaning of Hounsfield unit 4. And here is an ugly looking irregular border, hemorrhage, calcification. This is very, very suspicious for adrenal cancer. Okay. Type predictors of cancer. How do we predict cancer versus benign? Size or Hounsfield units. So size, anything more than 4 centimeters in size is worrisome. I'm not saying cancer. يعني pay attention. So anything more than 4 is worrisome. I have to give it more attention. Masses larger than 4 centimeters have higher risk of being cancer, adrenocortical carcinoma, higher risk. Right. What about the Hounsfield unit? Hounsfield unit is a software measurement. The radiologist, when he's looking in his office on the imaging of the CT scan, في عنده tool, okay, اللي هي attenuation. He clicks on it, بيطلع له a small circle that he can shift and move all across the image. And he puts it on the adrenal gland and it measures the attenuation. It gives him an output. A number is given out. This is what we call Hounsfield units. طيب. Hounsfield unit less than 10 in an adrenal mass is benign, no doubt about it. Hounsfield unit on a non-contrast image above 10 is suspicious. تمام? So that's one thing. When we order an adrenal CT for a patient, طبعا when you put the order in the system, you have to specify, do you want it with contrast or without contrast? When I order these images, I order abdominal CT without and with contrast. This is how I do it. So the patient goes to radiology. On the table, they start off with a non-contrast CT scan, and they look at the image. And then in the operator's room, they will measure quickly the Hounsfield unit on the adrenal mass. If it's less than 10, the study is complete. خلصنا. We don't need contrast. تمام? If the Hounsfield unit was more than 10, they would administer the contrast and scan the patient again. And they will calculate, or the radiologist will give me something called the washout. The washout is how quickly does the contrast go into the mass and comes out of it within 10 or 15 minutes. So they give me a number. The washout, I don't want you to worry about the numbers, just the concept. If the washout is high, this is a benign mass. If the washout is low, يعني the contrast is going into the mass and staying there for a longer period of time and coming out slowly, meaning low washout, this is suspicious. خلينا ناخد شوية scenarios. A 5 centimeter mass with Hounsfield unit, non-contrast Hounsfield unit 20, and low washout. What is this? Highly suspicious of cancer. It's not diagnostic, but highly suspicious of cancer. Another scenario. An 18 centimeter adrenal mass, Hounsfield unit minus 70.
18, the side.
It's huge, صح؟
Yes.
بس الهاوسفيلد unit is بالminus. So this is an example of this. You see this huge mass?
Hello.
لا مو myelolipoma مو myeloma. Yeah, but it's good. المايلوما ايش هي؟ مرض بالدم بالبون مارو. This is myelolipoma. A huge mass. The density تبع الهاوسفيلد unit is بالminus. This is one of the exceptions of the 4 centimeter cutoff that I told you about. لأنه if it's in the negative, I know that it's a benign mass. I don't need to take it out. Like one might ask, طب يا دكتور, why did they take out the mass here? Mass effect. غالبا is basically because of the size, it's causing abdominal pain, but not because it's cancerous, not because it's over-secreting hormones. So that's the only exception for the size criteria. When we know it's a myelolipoma based on negative Hounsfield unit. So it's a benign lesion. A third scenario. Yes.
The attenuation is low just because of the lipoma.
Exactly. And 0 is the attenuation of water. So بالminus, you're talking about fat-rich mass. And fat-rich masses are benign. الكانسر عادة بيكون في عندي densely packed cancer cells. ما بيكون في fat. Okay? This is full of fat. It's a myelolipoma. Another scenario. A 3 centimeter mass, a 3 centimeter right adrenal mass with Hounsfield unit on a non-contrast image of 12. What should we do next? Contrast. ممتاز. أعطينا contrast and it's high washout. benign. ممتاز. Most likely صح كلامك. Clear? طيب. Now, the hormonal workup, we also talked about it. We measure metanephrines, we measure hormones related to Cushing, and we measure aldosterone only if the patient is hypertensive. We talked about this before. Right, so treatment in general, هناخدهم one by one scenario. If the adrenal mass is hormonally active, adrenalectomy. We agree on this. إذا كانت FIO ولا hyperaldo ولا Cushing, you have to take it out. Another scenario, if it's more than 4 centimeters at the initial presentation, not a myelolipoma طبعا, take it out كمان. لأنه the chance of cancer increases with time in these cases. If high suspicion for cancer, adrenalectomy, like what? 3 centimeters, high Hounsfield unit, low washout. This is really suspicious. حتى لو ما كانت 4 centimeters, I would take it out. طيب, نجي للبايوبسي. perform biopsy only if the patient has another primary tumor or cancer, another primary cancer. And you need to know if this metastasis from the other cancer, or is it a primary adrenal mass? Scenario, I have a patient with colorectal cancer, underwent left hemicolectomy, تمام? Seems to be in remission. On a PET scan, بعد سنتين, they noticed uptake on one of the adrenal glands. We did Hounsfield units and they're high. Washout is high. So this is a very suspicious mass, صح? Now I'm thinking, is this metastatic colorectal cancer, which we can treat maybe by another agent, مو بالضرورة يكون surgery. ممكن نعطي a course of chemotherapy. Or is this mass a primary adrenal malignancy? In this case only, we can do a biopsy to distinguish between a metastatic cancer or a primary adrenal cancer. لأنه primary adrenal cancer, we cannot give chemotherapy. We have to resect the tumor. So that's the only time a biopsy is helpful. Yes.
So the case is simple.
صح.
And you get it to check.
صحيح. 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 So this mass is not hormonally functional. عرفت علي? It's when a metastasis attacks the adrenal gland, it would never cause oversecretion. Oversecretion of the hormones has to be a primary adrenal tumor. تمام؟ يعني colorectal cancer going to the adrenal ما حيعطيني Cushing. Breast cancer going to the adrenal ما حيعطيني Cushing أو hyperaldo. Yes, ممتاز. ممكن excellent. صح. ممكن يعطيني hypo، يعني يكون عندي adrenal sufficiency، ممكن يكون عندي mineralocorticoid deficiency. لكن the caveat is not just affecting one. لأنه even if it affected the synthesis in one gland, you still have the other one. So ما حيصير عندي Addison's، ما حيصير عندي other. لازم يكون bilateral metastasis in order to cause deficiency. لأنه remember, a human can live with only one adrenal. تمام؟ طيب. If rapidly growing, what does it mean? اليوم عندي 2 centimeter lesion. بعد 6 months, it's 3 centimeters. بعد 6 months, it's 3.5. I'm seeing serial growth. This is not very good, so we resect the tumor عادة.
Is it tumor resection only or the whole adrenal gland?
The whole adrenal. نحن دائما لما نتكلم بالادرينالكتومي we talk about the whole adrenal gland. شوف، في surgeons اليوم in this world, they try to do selective resection of the tumor. This exists يعني خصوصا بألمانيا شاطرين بهالأمور. So they do selective adenomectomy يعني they remove the adenoma and they leave behind. It's not mainstream and it's not very recommended صراحة. But there are those surgeons who do it this way. طيب. If not hormonally active, if less than 4 centimeter in size, وما عندي rapid growth on serial imaging, what should I do? Leave it. Leave it and follow it. Okay? I have a lot of patients in this category. كتير عندي بالclinic. I follow them every year with an imaging, or every 2 years with biochemical testing. I see that the tumor is stable in size. They are fine. History, physical is not suggestive of anything. Biochemical testing is fine. Come back to me after 1 year. Okay? Common scenario. So what's the role of adrenal biopsy? نرجع نأكد عليه. Only when there is a question of metastasis to the adrenal gland, which will change the management of the cancer. A biopsy does not differentiate adenocortical carcinoma from adrenal adenoma. يعني I would just know from the biopsy that this is adrenal أو non-adrenal. بس ما حتقول لي إنه this is adrenal cancer. Okay? You have to rule out FIO before sticking a needle into any adrenal mass. Okay? It's very serious to put a needle بدون ما نكون عملنا 24-hour urine metanephrine. What can happen? Hypertensive crisis or something. And I have to tell you that in my career so far, I have 3 patients يمكن اللي تشخصوا بفيوكروموسايتوما based on a biopsy. Can you imagine? It was done by يعني mistake. One of them did have an adrenal يعني an hypertensive urgency after the biopsy. طيب. So it can happen. Alhamdulillah, I would never do it. لكن sometimes I can give you a scenario. مثلا ممكن يكون المريض يعني مع احترامي لكل الزملاء يعني بس ممكن يكون المريض راح to a non-specialist and they thought of common sense يعني إنه put a needle in it. مثلا urologist أو حتى non-specialized oncology. It can happen. These things can happen, unfortunately. Yes.
If it's silent view,
few constant, like we have the 24 hours.
Yes, silent فيه معناتها ما في عنده symptoms, بس when you do the metanephrines in the urine, it will be high. Okay? Otherwise, we would not call it فيه. يعني إذا ما في symptoms وما عندك elevated metanephrines, it's not a pheochromocytoma. طيب نحكي على الادرينال كانسر. It's rare, 1 to 2 per million. In adults, present usually in the 4th or 5th decade, more common in men. It's one of those aggressive cancers مع الأسف. يعني if I have to rank the worst endocrine cancer, I would put number 1. Who can guess what? This is حلو. شوف, I'll tell you something. The pancreatic cancer that you're talking about is an exocrine cancer, not an endocrine cancer. تمام؟ في عنا pancreatic cancers اللي هو neuroendocrine tumors ممكن, بس they're not so aggressive. So what's the number 1? مين ممكن يحذر ده؟ Endocrine cancer. لا, endocrine cancer that you learned about. Not medullary, anaplastic. Anaplastic is the worst, in my opinion. Number 2, I would put adrenal cancer. Okay? هلا medullary is not terrible, by the way. Medullary is still manageable. We have a lot of ways to handle it. في عنا chemotherapeutic agents, في عنا tyrosine kinase inhibitors, and we can handle typically medullary thyroid cancer in a nice way. طبعا there are those extreme cases which are fatal ممكن, but not the usual. طيب 60% are hormonally active and present usually with Cushing's syndrome in men and Cushing's syndrome and hyperandrogenemia in women. ممتاز. Again, let's think about this. I have an adrenal mass, ugly looking, on CT scan. It's huge, 10 centimeters. 60% of the time, حيكون on top of that cancer في عندي Cushing. It's producing a lot of cortisol. And in females, it can also produce androgens. So the female will come to me with Cushing and virilization, excessive facial hair, clitoromegaly, all the hyperandrogenemia. So حتى the combination of Cushing with hyperandrogenemia is a predictor of adrenal cancer when you have it. Right. How do you treat adrenal cancer? The first thing to do is surgery. The second thing, طبعا, we use chemotherapy. One of them is oral agent called mitotane. We give it to patients. Well, there are other forms of chemotherapy, systemic, that oncologists give to those patients. ولما يكون عندي metastasis, we have to deal with the metastasis separately. يعني, let's say I have a right adrenal cancer with Cushing. Right adrenal cancer with Cushing. طيب. What is the primary treatment that I'm going to do for this patient? Surgery. صح? لكن it's metastatic. Meaning I have in the lungs some foci of metastatic cancer, in the liver some foci of metastasis. Taking out the primary cancer is very helpful. It will improve the situation of the patient, but it will not resolve everything. يعني المريض لسه حيكون عنده Cushing, بس حيتحسن الكوشنج لأن metastatic sites are hormonally active as well. Okay? So here we have to think of other ways to tackle the other metastases. مثلا, maybe we can do partial resection of the liver. Maybe we can do radiofrequency ablation to tackle those metastatic lesions. So it's quite complex and challenging. If I cannot control Cushing by surgical resection of this metastasis, I have to think of medical therapy. ممكن نستخدم ketoconazole, ممكن نستخدم metyrapone, ممكن نستخدم mifepristone and other medications to control Cushing, which we learned about before. Okay. طيب, 2 more topics to cover. We still have time. Congenital adrenal hyperplasia is an inborn error of metabolism. There are probably tens of enzymes that can cause congenital adrenal hyperplasia. What I will discuss with you is just one example, which is the most common example. It accounts for about 95% of cases of congenital adrenal hyperplasia. It's called 21-hydroxylase deficiency. 21-hydroxylase deficiency. It's autosomal recessive. طيب, let's look at this steroidogenesis pathway and try to understand the pathophysiology. So a human being is in utero now, okay? A fetus has decreased 21-hydroxylase enzyme activity, inborn error of metabolism, okay? That's how the patient is born. طيب, what will happen? Now let's try to think. We start here with the cholesterol molecule, and I have a deficiency in this enzyme. the body will convert pregnenolone to progesterone, and then will go down to 17-hydroxyprogesterone and trying to overcome this enzyme. But no, there is very little enzyme activity. So I will end up with what? Low cortisol. طيب مين حيزعل هلا؟ لما يكون عندي low cortisol مين حيزعل؟ البيتيوتري حتزعل صح؟ What would it start doing? High ACTH. ممتاز. So now with increased pressure on steroidogenesis, I'm able to overcome a little bit of this roadblock. So I'm getting barely enough cortisol, but at the expense of very high ACTH. حلو كتير. ACTH will drive the pathway downwards, will push downwards. What will it give me? More testosterone. So imagine this fetus being a girl, a female. حيصير عندي virilization. So she will be born with ambiguous genitalia. ليش؟ لأنه the genitalia of this baby were exposed to high levels of testosterone and dihydrotestosterone in utero. So she will be born with ambiguous genitalia, clitoromegaly وهالكلام هذا. Okay? And this is how these patients are usually picked up. But when they're born, pediatrician بيفحص البيبي يعني immediately ambiguous genitalia, they start thinking of those causes. فبيعملوا testing وهالكلام هذا. طيب. Now let's try to. So طبعا another thing we didn't talk about is aldosterone also will be low in these patients. Not all the time, sometimes in some cases بنسميهم salt losing congenital adrenal hyperplasia. So for the salt losing بيكون عندي deficiency بالcortisol and the mineralocorticoid. Girls present with ambiguous genitalia, rarely adrenal crisis if genitalia not too deformed. Boys typically present with adrenal crisis. فكمان سألوني الفيميلز why the distinction؟ السبب إنه the girl that is born with ambiguous genitalia, we pick up adrenal crisis or we pick up congenital adrenal hyperplasia and aldosterone deficiency early on. We do the testing while she's in the hospital. بالمقابل, a male fetus or a male baby born, regular genitalia and having this deficiency, the symptoms are some weakness, poor suckling مثلا, but maybe the patient will be sent home على أساس ممكن يتحسن مع أمه. 3, 4, 5 days down the line, they will present again to the emergency room with adrenal crisis. Okay, so that's the difference يعني in the pediatric age group أو newborns. And non-salt losing بيعطونا شيء اسمه ambiguous genitalia in girls طبعا. This is clitoromegaly in a patient with 21 hydroxylase deficiency. طيب, so now we talked about one of the famous conditions about congenital adrenal hyperplasia, which is 21 hydroxylase deficiency, the classic form. Here is an example of something called non-classic 21 hydroxylase deficiency, which present in later life, after puberty. These are young women presenting with hirsutism and amenorrhea. The clinical features are exactly like PCOS. So you cannot distinguish polycystic ovary syndrome from non-classic 21 hydroxylase deficiency by symptomatology only. They are very similar. But how do we distinguish between the two? By high levels of 17-hydroxyprogesterone. Meaning, if I get any patient with features of PCOS, I have to rule out non-classic 21 hydroxylase deficiency. How do I rule it out? Blood test. I just measure 17-hydroxyprogesterone. But where is 17-hydroxyprogesterone on this pathway? It's right here. Right here. So if I have a bottleneck in the 21 hydroxylase enzyme, what happens to this? Increase. It will be high. So if I have a patient coming to me, 25 years old, يا دكتور أنا من 6 شهور, I have amenorrhea, I have excessive facial hair, I'm shaving a lot, وبعدين I want to know what's happening. I order testing. I order the androgens, LH, FSH, prolactin, كل هالكلام, and 17-hydroxyprogesterone. If the 17-hydroxyprogesterone is high, I have a diagnosis. If not, it's probably PCOS. Okay? Fine. ممتاز. How do we treat congenital adrenal hyperplasia, whether it's classic or non-classic? Treatment is generally the same. If it's salt losing, we have to give mineralocorticoid. If it's not salt losing, only we have to give them steroids. لكن طبعا if you look in the literature or in your books or whoever teaches you about congenital adrenal hyperplasia, they might give you a very different way of treatment. This is the way I treat it. فيها كتير يعني مذاهب إذا صح التعبير. There are many ways to treat congenital adrenal hyperplasia. حتى أنا, my colleagues in the same department, we are different. The way I do it, I give them dexamethasone at night. Why dexamethasone at night? I want to suppress the ACTH. لأنه especially in females, what's driving the androgens now? ACTH. طب I want to stop this driver. So I give them dexamethasone at night, small dose, 0.25. Now, what will happen to their cortisol after giving them dexamethasone? خلينا نشوف الفيجر. خلينا نشوف الفيجر مرة ثانية. So I start with very high ACTH and barely enough cortisol and a lot of androgens. So now I'm giving a dexamethasone at night to decrease the androgens. I want to decrease the androgens. So what will happen to my cortisol when I decrease the push? Cortisol will go down. لأنه with high ACTH, I was able to get شوية cortisol with high ACTH. But when I decrease the ACTH, because I want to have less androgen, my cortisol will go down. So I replace them with hydrocortisone, just like adrenal insufficiency. فبعطيهم dexamethasone at night, and I give them 10 milligrams of hydrocortisone in the morning, 5 milligrams in the evening. Just like adrenal, لأنه I'm causing adrenal insufficiency in these patients by giving dexamethasone. Clear? زبطت معك ولا لسه؟ طيب ممتاز. على فكرة you can يعني I can explain more إذا حبيت. طيب ممتاز. So طبعا these patients need stress dosing when they're sick وكل هالكلام هذا, the usual stuff. ممتاز. We're gonna close with one last topic. طبعا nothing new here. One last topic which is called polyglandular autoimmune syndrome. We talked about it already. يعني a cluster of autoimmune endocrine problems happening at the same time. We mentioned them. Hashimoto, Graves, type 1 diabetes, autoimmune hypopara, primary adrenal insufficiency اللي هي Addison's disease, premature ovarian failure, vitiligo. كل هالsyndromes هدول, they are considered autoimmune syndromes. If they happen as a cluster in a patient, it's likely that they're either autoimmune polyglandular syndrome 1 or 2. So it's just a way of classifying those patients. What I want you to remember is that type 1 is linked to a specific gene usually, which is AIRE gene. That's one thing. Another thing is onset in infancy usually in type 1. So if you have a patient with history of these conditions starting from a very young age, it's likely to be APS1. And there are two important distinctions. The hypoparathyroidism and the mucocutaneous candidiasis only happens in type 1. Okay? The rest are shared. Yani type 1 diabetes, adrenal insufficiency, they're shared between type 1 and type 2. If we look at type 2, many genetic conditions, usually in the older age, and it's more common. طيب? Just يعني a bit of distinction between the two. So if I have a patient coming with this feature, these features, type 1, تمام? This is mucocutaneous candidiasis, and this is basically fungal infection of the nails, usually treated with antifungals. So autoimmune polyglandular syndrome type 1, we talked about it, mucocutaneous candidiasis, autoimmune hypopara. Now, they don't have to have everything at the same time. يعني المريضة اللي حكيت لكم عنها, the one who's presenting with autoimmune hypopara, which I saw her yesterday, she doesn't have any of this. So it might be isolated. ما في عندي other things, okay? Isolated hypopara, which is autoimmune. لكن if she comes to me later on with adrenal crisis, وبعد 5 سنوات with مثلا what type 1 diabetes, most likely she is type 1, although type 1 usually presents in a younger age. يعني there is always an exception for everything. طيب. APS2, 2 or more of the following, we talked about it, non-specific gene mutation, And one last thing is organ-specific autoantibodies are often present even in the absence of overt clinical disease. What does that mean? يعني ممكن اليوم مريض عندي with autoimmune polyglandular syndrome with type 1 diabetes and adrenal insufficiency. حلو? I measured TPO antibodies. TPO antibodies is for what? For Hashimoto, صح? I might find that the TPO antibodies are elevated, but does that mean the patient has Hashimoto? No. So Hashimoto is a clinical diagnosis and the biochemical diagnosis, not an antibody-based diagnosis. So here, specific autoantibodies are often present, even if in the absence of clinical manifestation. So معناها I would not screen patients by doing the antibodies. I would screen them by doing the hormones themselves. واضح؟ ممتاز. And with that, I think we end here. هذا متابعين. نعم بس سكر هاي عادي.
Yeah, we're not using it anymore.
Okay.